Tubercular meningitis comprises 1% of tuberculosis, but the case fatality over here is higher, 15 to 40%, and disability neurological handicapping is quite high, up to 50%. So thereby, it is important. The risk factors over here are measles, protein energy malnutrition, malignancy, and HIV infection. 40% of cases of tuberculosis is below 2 years old child, and 50%, 70% below under 5. The meningitis has a gradual onset with raised intracranial pressure features, cranial nerve palsy features, seizure, neck stiffness, cardiac signs as usual, and paralysis, stroke, the your EPS, and decerebral rigidity, extrapyramidal syndrome, and decerebrate decorticate rigidity. They were frequent once upon a time. Nowadays, still they are present in the neglected cases, late cases. So the diagnosis of these cases by CSF study, the WBC count, predominantly lymphocyte 100 to 50 cells per liter or so, the protein elevations 100 to 500 something, and then glucose reduction maybe 0, and AFP positivity by Jill-Nelson stain or smear positivity, ADA positive raised ADA, and gene expert. MRI CT is not usually needed, but it is needed to diagnose hydrocephalus, tuberculoma, abscess, and brain edema, cranial neuropathy. The proton MRS at times detect intracranial space occupying lesion. So diagnosis is followed by immediate therapy, your 4 drugs for your longer time, 9 months to 18 months, 12 to 18 months is standard. So 4 drugs, INS, rifampicin, pyrazinamide, and ethambutol, and intensive phase, followed by other few months with the 2 drugs, your continuation, and prednisolone can be given for 1 to 6 weeks to prevent the adhesion and sequelae or complications. As I said earlier, dexamethasone 0.4 to 0.2 milligram may be nice over here, and by tapering manner. And SEAT cases or cerebral salt wasting syndrome needs fluid restriction and fluid infusion respectively. INS prophylaxis at times to contact people has a report of decreased incidence of this severe sort of tuberculosis.